Welcome everyone to this video on cerebral dysfunction. If today is your first time here, please subscribe, like, and share. The brain is like the body's command center, and when something goes wrong, it affects every system. Whether you're a nursing student or just curious, understanding cerebral dysfunction gives you insight into trauma, infection, seizures, and more. So let's make the complex stuff simple, one slide at a time. The brain, while remarkably protected by the skull, is susceptible to increased pressure within the cranium. This increased intracranial pressure, or ICP, can have significant consequences. As ICP rises, the signs and symptoms become more noticeable, and the patient's level of consciousness can decline. Remember that early detection is key, as initial signs can be subtle. Think of the skull like a closed box. If anything inside it swells, blood, fluid, or brain tissue, there's nowhere for it to go, which increases pressure. That pressure compresses brain tissue and can damage nerves. Nurses must catch even the smallest signs early, like slight confusion or subtle restlessness. In infants, increased ICP presents with unique clinical manifestations. Look for irritability, poor feeding, tense or bulging fontanelles, and the setting sun sign in the eyes. A high-pitched cry that's difficult to soothe, separated cranial sutures, and distended scalp veins are also important indicators. Older children may exhibit headache, forceful vomiting, seizures, drowsiness, and an inability to follow simple commands. Babies can't tell you what's wrong, so observation is key. Bulging fontanelles or a high-pitched cry may be early warning signs. In older kids, they can verbalize headaches or nausea, making diagnosis easier. Always compare behavior with the child's norm. The setting sun phenomenon is a key indicator of increased ICP in infants. It's characterized by the eyes appearing to gaze downward, with the sclera visible above the iris. Recognizing this sign early can be crucial for timely intervention. Late signs of increasing ICP are critical indicators of a worsening condition. These include bradycardia, decreased motor and sensory responses, alterations in pupil size and reactivity, and abnormal posturing like extension or flexion. Decreased consciousness and ultimately coma are also late-stage signs that require immediate attention. These are signs that things are getting dangerously worse. If a patient becomes unresponsive, has unequal pupils, or starts posturing, this is an emergency. Immediate intervention can mean the difference between recovery and permanent damage. Consciousness is a state of awareness, encompassing both alertness and cognitive power. Altered states of consciousness exist on a spectrum, ranging from brief periods to indefinite states. Coma represents the most severe form, where the patient is unresponsive and cannot be aroused. From mild confusion to coma, changes in consciousness often come first before other symptoms. Nurses need to note even small changes. Is the patient sleeping more? Confused? Does their response to questions seem delayed? Levels of consciousness can be categorized to help assess a patient's neurological status. These range from full consciousness to confusion, disorientation, lethargy, obtundation, stupor, coma, and finally, a persistent vegetative state. Each level represents a different degree of awareness and responsiveness. The Glasgow Coma Scale, or GCS, is a vital tool for coma assessment. A decrease in the GCS score indicates neurological deterioration. Remember that brain death is defined by the complete and irreversible cessation of brain function. A thorough neurologic assessment includes evaluating pupils, eye opening, motor response, and response to stimuli. This is one of the most used tools in neuro assessments. It scores eye opening, verbal, and motor responses. A score of 15 is fully alert. A score of 3, deep coma. Nurses use this to track changes and guide interventions. Let's consider a practical scenario. A 17-month-old found unresponsive. Using the Glasgow Coma Scale, we can systematically assess their neurological status. Evaluate pupil response, eye-opening, motor responses, and responses to stimuli. Also, assess hand grip, muscle tone, Fontanel condition, eye movement, and mood. When faced with a real situation like a toddler after a fall, it's crucial to assess using GCS eye response, opens to pain, to motor, flexion, decorticate, and which are 3 verbal, not age-appropriate response, and 3 total, GCS of 8. This indicates severe injury. A comprehensive neurologic examination is essential for assessing cerebral function. This includes reflexes, balance, cranial nerve checks, and watching for asymmetry in movement. Always compare left versus right sides and upper versus lower limbs. Nursing care plays a crucial role in the outcome and recovery of an unconscious child. Effective nursing care and keen observational skills are paramount. Emergency management focuses on airway management, reducing ICP, and treating any signs of shock. ICP monitoring is indicated in specific situations. These include a Glasgow Coma Scale score of less than 8, traumatic brain injury with an abnormal CT scan, a deteriorating neurologic condition, and based on clinical judgment. Several nursing activities can help manage increased ICP. Proper patient positioning, avoiding neck vein compression, using an alternating pressure mattress, and elevating the head of the bed are important. Also, avoid activities that may increase ICP, minimize environmental noise, and carefully manage suctioning to prevent aspiration. Avoiding neck flexion, keeping the head midline, and using quiet environments can reduce spikes in pressure. Even things like excessive suctioning or turning the patient too quickly can raise ICP. Medications play a key role in managing increased ICP. Antibiotics are used for infectious processes, while corticosteroids address inflammation and edema. Sedatives or antiepileptics may be necessary, and in some cases, barbiturates or paralytic agents might be considered, though these are controversial. Treatment depends on the cause. If infection, antibiotics, swelling, corticosteroids, seizures, antiepileptics. Sedatives may help lower metabolic demand, but paralyzing agents are used with extreme caution. Pain assessment in comatose children requires astute nursing observation. Signs of pain include increased agitation, rigidity, increased ICP, and changes in vital signs. While opioids are sometimes used, they are controversial. Fentanyl, midazolam, and vecuronium are potential options. Acetaminophen and codeine may also be used, ensuring adequate dosage and regular administration. Comfort measures and a quiet, dimly lit environment are also important. You won't hear "I'm in pain" from an unconscious child, but signs like increased heart rate, facial grimacing, or stiff limbs can be telling. Monitor vitals during care activities and provide comfort even if the child seems unaware. Cerebral trauma can result from various causes in childhood. Falls, motor vehicle injuries, and bicycle or sports-related injuries are common culprits. These events can lead to significant head injuries and brain damage. Primary head injuries are those that occur at the time of physical trauma. These include skull fractures, acceleration-deceleration injuries, contusions, intracranial hematomas, and diffuse axonal injury, which involves tearing or shearing of nerve fibers in the brain. Epidural and subdural hematomas are types of intracranial bleeds that can occur after head trauma. Tentorial herniation is a dangerous complication where brain tissue is displaced due to increased pressure. Understanding the anatomy and potential complications is crucial. Concussion symptoms can vary, but some warrant immediate attention. These include one pupil larger than the other, drowsiness or inability to wake up, a worsening headache, slurred speech, weakness, numbness, decreased coordination, repeated vomiting, seizures, unusual behavior, increased confusion, restlessness, and loss of consciousness. Even a brief loss of consciousness should be taken seriously. Consider this scenario. A 5-year-old hits her head and initially seems okay, but later complains of vision problems. This highlights the potential for delayed responses in head injuries. It's crucial to monitor patients closely, even if they initially appear stable. In toddlers and infants, specific concussion symptoms require immediate attention. These include any of the general concussion signs, persistent crying that cannot be consoled, and refusal to nurse or eat. Contusions are visible bruises, while lacerations involve tearing of tissue. A coup injury occurs at the point of impact, while a contra-coup injury occurs on the opposite side of the brain. Remember that multiple sites of injury are possible. The contra-coup injury is a secondary impact that occurs when the brain moves within the skull after the initial blow. This can result in bruising at a site far removed from the point of impact. Skull fractures can be classified into several types. Linear fractures are single fracture lines, while depressed fractures involve bone fragments pushed inward. Comminuted fractures involve multiple linear fractures. Basilar fractures occur at the base of the skull and may involve a dura tear. Open fractures involve both the skull and scalp, and growing fractures involve a dura tear that doesn't heal properly. Hemorrhages and cerebral edema are serious complications of head trauma. Epidural hemorrhages occur between the skull and dura, while subdural hemorrhages occur between the dura and arachnoid membrane. Cerebral edema is associated with traumatic brain injury and can lead to increased ICP and herniation. Diagnostic evaluation of head trauma involves several steps. Begin with a detailed history and assessment of airway, breathing, and circulation. Evaluate for shock, perform a neurologic examination, assess level of consciousness, and monitor vital signs. Special tests like CT scans, MRIs, and behavioral assessments may also be necessary. Therapeutic management of head trauma depends on the severity of the injury. Hospital care is required for severe injuries, prolonged loss of consciousness, or continued seizures. Oral administration is initially avoided. Surgical therapy may be necessary. Prognosis varies depending on the extent of the injury. Drowning leads to hypoxia, aspiration, and hypothermia. Hypoxia can cause pulmonary edema, atelectasis, and airway spasm. Hypothermia is a significant risk due to the large surface area to body mass ratio in children. Emergency resuscitative efforts are crucial in drowning incidents. Management depends on the degree of cerebral insult. Aspiration pneumonia is a frequent complication. Hospitalization for observation is necessary. Prognosis depends on the length of submersion, and long-term care management may be required. Bacterial meningitis is an acute inflammation of the meninges and cerebrospinal fluid. The incidence has decreased since the introduction of the Hib vaccine. It can be caused by various bacterial agents, including Streptococcus pneumonia, Neisseria meningitis, Group B Streptococci, Staphylococcus aureus, and Escherichia coli. Bacterial meningitis can be transmitted through droplet infection from nasopharyngeal secretions, extension of other bacterial infections, and spread through CSF. The risk increases with the number of contacts, and there's a seasonal variation, with late winter and early spring being peak times. Therapeutic management of bacterial meningitis includes isolation precautions, antimicrobial therapy, maintaining hydration, ventilation, reducing increased ICP, managing shock and controlling seizures and temperature. Drugs used in treatment include empirical therapy, dexamethasone, and antibiotics. Prognosis depends on the organism and promptness of treatment, and patients may experience sequelae. Brudzinski's sign and Koenig's sign are physical indicators of meningitis. Brudzinski's sign involves flexion of the hips and knees when the neck is flexed. Koenig's sign involves an inability to straighten the leg when the hip is flexed to 90 degrees. Let's test your knowledge. When do fontanelles close? The anterior fontanelle typically closes between 7 to 18 months. The posterior fontanelle usually closes around 2 months of age. Posterior fontanelle closes at 2 months. Anterior closes between 7 to 18 months. Delayed closure can indicate hydrocephalus or increased ICP. Reye syndrome is a toxic encephalopathy associated with organ involvement. It's characterized by fever, impaired consciousness, and disordered hepatic function. The cause is not well understood, but most cases follow common viral illnesses like influenza and varicella. A potential association exists between aspirin therapy for fever and the development of Reye syndrome, linked to aspirin use in kids with viral illnesses. It causes liver and brain swelling. This is why aspirin is avoided in children unless specifically prescribed. Lead poisoning can have devastating effects, including damage to the brain and nervous system, slowed growth and development, learning and behavior problems, hearing and speech problems, lower IQ, decreased attention span, and underperformance in school. Symptoms include headaches, stomach cramps, constipation, muscle joint pain, trouble sleeping, fatigue, and irritability. Common in homes with old paint or plumbing. It affects learning, growth, and behavior. Testing blood lead levels in at-risk populations is key. Diagnostic evaluation of Reye syndrome includes a liver biopsy. Therapeutic management involves early diagnosis and aggressive therapy. The prognosis for recovery is generally good, considering the gravity of the disease. Liver biopsy confirms the diagnosis. Early detection improves outcomes. Parents must know not to use aspirin unless advised. Seizures are caused by excessive and disorderly neuronal discharges in the brain. They are determined by the site of origin and are the most common neurologic dysfunction in children. A seizure is a symptom of an underlying disease process. Nurses should be able to distinguish partial versus generalized seizures. Document what you observe: timing, movements, consciousness. Treatments vary from meds to diet changes or even surgery in refractory cases. Epilepsy is characterized by 2 or more unprovoked seizures. It can be caused by various pathologic processes in the brain. Optimal treatment and prognosis require an accurate diagnosis and determination of the cause. Causes can be acute symptomatic, remote symptomatic, cryptogenic, or idiopathic. Seizures can be classified as partial, generalized, or unclassified. Partial seizures have a local onset and involve a relatively small area of the brain. Generalized seizures involve both hemispheres without local onset. Therapeutic management of seizure disorders aims to control seizures or reduce their frequency and severity. Discovering and correcting the cause is also important. Management strategies include drug therapy, ketogenic diet, vagus nerve stimulation, and surgical therapy. Identifying triggering factors and enabling patients to live as normal a life as possible are key goals. Febrile seizures are a transient disorder of childhood, affecting approximately 2% to 5% of children. They usually occur between 6 months and 3 years of age and are rare after age 5. They are twice as frequent in boys. The cause is uncertain, but they are often associated with viral infections, often triggered by sudden fever spikes, especially in toddlers. They look scary, but most are harmless. Reassure families and monitor for recurrence. Hydrocephalus is caused by an imbalance in the production and absorption of CSF. Pathophysiology includes impaired absorption of CSF, obstruction through the ventricular system, and communicating and non-communicating hydrocephalus. Treatment typically involves shunt placement. Therapeutic management of hydrocephalus often involves placing a shunt to drain excess CSF. MRI scans can help visualize enlarged ventricles, a characteristic of hydrocephalus. Shunt infections are a significant concern after shunt placement. The period of greatest risk is 1 to 2 months after placement. Types of infections include septicemia, bacterial endocarditis, wound infection, shunt nephritis, and meningitis. Treatment involves massive dose antibiotics or shunt removal. A shunt drains excess fluid to the abdomen. Monitor for shunt malfunctions, headaches, vomiting, or bulging fontanelles. Infections can be life-threatening and may require shunt removal.